Hotbed Talk.
It's a great pleasure to introduce the session this morning, which we're chairing jointly with the Anaesthesia Collaborative. I'm going to introduce Tim Wigmore, who is a consultant anaesthetist and intensivist at the Marsden Hospital, and who's going to talk to us about volume and outcomes in cancer. Thank you.
Thanks so much, Denny, and welcome everybody. Thanks so much for coming along to this session. Great pleasure to be able to talk to you today about oncoanesthesia, subject in which I've had a lot of interest for the last 20 years. It's one of those sort of burgeoning areas in which we've discovered that a focus on specialization and a development of the research can have major impacts on patient outcome. And I think, if you look at the progress over the last sort of 5 to 10 years, it's really accelerated away. And I think that's now starting to translate into practice change, not just in the major centres, but in a wider context. And that's some of what we're going to be talking about today. We've got a fantastic panel who are going to be joining me. Dr. Shaman Jhanj, who is a colleague at the Royal Marsden, our head of anaesthesia and intensive care research. He's been responsible for really developing our program over the last 10 years. He's got a very broad personal research portfolio in addition to collaborating everything else that we're currently involved with. And he's the lead investigator for VAPOR-C, which is a study which you may have heard of. We've also got Professor Dan Martin, who is come all the way up from Derriford, where he's Professor of Intensive Care and Anaesthesia. He's got a very broad range of titles, to the extent of which I can't remember them all, but he's certainly the editor of JICS, coordinator or PI of a number of major trials. He's involved in NIAA and on it goes. So we're extremely grateful to have you here today. And then we've got Blanche Simons, who's our patient representative, who we're hugely gratified to have with us today. She's an ex-patient of UCL and been cured. So we're really gratified to have her here today, and there's quite a lot in the patient space that I think we're going to be able to talk through today. So, Sham, if you'd like to come up and just introduce us to the topic, that would be great. Thank you.
So my name's Shaman Jhanj. I'm a consultant at the Royal Marsden Institute of Cancer Research in critical care and anaesthesia. So today we're going to talk a little bit about the process of care for cancer surgery, and in particular, we're going to talk about whether volume or high volumes in particular associated with improved outcomes. Now, I don't know about where you work, but we've got a number of surgeons who think of themselves as super surgeons who tell us how many of this procedure or that procedure they've done in the previous week, month or year. But certainly there is data suggesting that increasing volume, according to surgeon, is associated with improved outcomes, and I'll talk about that a little bit. But it's not only the surgeon, it's the institution. There's a number of people involved in the patient pathway. We'll often tell the surgeons it's simply because the radiologists have chosen the right patients who would benefit from the surgical technique. The oncologists look at their neoadjuvant chemotherapy or radiotherapy that's an important part of the pathway and improves the outcome for patients. And then, of course, there's us, the sort of perioperative physicians and anaesthetists. And Tim asked me to present a paper which looks particularly actually at anaesthetic volume for major complex surgery and whether that's associated with outcome. And that was published in JAMA Surgery a couple of years ago. As Tim said, it's great having Blanche here because I think, what do patients think about sort of the centralisation of care? Do people actually want to travel? We've all been involved in COVID for the last 2 or 3 years, unfortunately. And I think for all of us, particularly in critical care, one of the hardest things was treating patients without them being able to have relatives visit them. And I think that was obviously most importantly challenging for the patients, for the relatives, but I think also for us. And those kind of communication issues were a problem. So actually moving a patient 5 hours down the road to a regional centre, is that actually what patients would want? There's not a great deal of data on that, but we found snippets of that in the literature. And so then on to a discussion with the rest of the panel. So I think I'll go through some of the potential topics we could discuss, but should we be centralising all major cancer surgery? Is that still an issue in the 2020s? Some of the original data is from the early 2000s. Is that still an issue? Is there a ceiling effect? Once you're doing a few, is that enough? I don't know. And should it be only for certain types of procedure? Is volume just a surrogate of other things? And I think, again, that's something for discussion. Is it simply that we've got better processes of care, better team working? And again, I think we can discuss that later as a group. And then I think, particularly because we're talking about perioperative medicine and perhaps this paper which looked at volume for anaesthetists for specific procedures. Is there anything specific we're doing perioperatively that might impact outcomes for patients? Tim mentioned I'm involved at the moment. I'm co-CI for a trial of TIVA versus gas. There's many other interventions, whether it's around fluid, analgesia, pre-optimization or prehabilitation, that might impact on patient outcomes. So I think this was the first paper that looked at surgical outcomes and volume. This was published in 2003 by Berkmeier. This looked at about 500,000 patients in Medicare in the late 90s. They nested sort of regression models within this data set and looked at the impact of volume of surgery by individual surgeons and outcomes. And you can see here, particularly on this side here, with complex operations such as esophagectomy and pancreatic resections, there's certainly an impact of volume on surgical outcomes. Within this data set, they also looked at the impact of the institution. And again, you can see here with increasing hospital volume, you can see a gradual improvement in outcome. So suggesting that it's not only the surgeon that's important, but the institution. The authors didn't really comment on what they felt it was important within the institution that improved outcome. And again, it's likely to be multifactorial, but maybe related to the whole team, whether it's the radiologists, the oncologists, or probably the perioperative physicians involved. This group, the Leapfrog group, a group in the States who try and advocate for improved sort of patient safety, patient quality of care, but also value-based care for surgery in the US. And following this paper, they suggested that perhaps institutions should be looking at performing more than 20 of these highly complex surgical procedures, and individual surgeons more than 7 per year. So then Berkmeier and his colleague Finks published this paper, sort of in, I think, 2009, 2010, to look at the impact of these sort of leapfrog guidelines on outcomes for these major complex operations. Gradual reduction in mortality associated with time, which they wondered was due to this increasing centralization of care. Interestingly, this analysis was performed a bit later on, so it was published in 2019. So this looked at about 500,000 patients across Medicare up to 2016. What's really interesting is that actually, of those hospitals performing high-risk cancer surgery, only between 5 and 25% of them met those criteria set by Leapfrog. So actually, although people felt that there was some centralization of care, it didn't seem to be happening that much. However, they also looked to see if this effect was still existing at this time, because maybe from the 2000s, after this was highlighted across the States, maybe this effect had been lost, that actually high-volume hospitals were still associated with odds ratios of around 0.6 to 0.8 for mortality. So still suggesting that there was an association between high-volume institutions and better outcomes. So is it the institution or the surgeon? This is a meta-analysis looking in colorectal surgery. So this looked at about 50 studies and about 1.2 million patient episodes. And if you start here in the bottom right with a reference, this is a sort of low hospital, low surgeon volume group, given a reference mortality of 1. If you move to a high hospital volume but a low surgeon volume, there is an impact. So the rest of the team is important. It does seem to improve outcomes. However, you do get a bigger effect if the surgeon is also a high volume surgeon. So it does appear again that this issue does seem to still exist in modern medicine. So what about the patient? And I think this is really important. If you look, there's lots of data from the States. And again, I apologize. A lot of the data around this area of work is from North America. So again, I think that's one of the topics perhaps we can discuss, how well this applies to other sort of healthcare organizations and countries. But if you look at data from the States, there's lots of data looking at how far patients travel for major complex surgery. And I think one of the best sort of defined examples is gastrectomies. And in fact, most patients don't travel that far for an operation to remove their stomach. They will go to their local hospital and not travel the extra distance to the regional cancer centre. Now, again, many of these studies simply look at what happens, don't try and look at the reasons. But this was, well, the only study I could find anyway, with Tim's help, to be honest, looking at why patients might make these decisions. And I think that's really important. So when patients are looking at where to go, I think the most important factors are these: confidence in the physician and doctor recommendation. So if a doctor recommends your operation in the hospital you're in, you'll probably go for it. Why wouldn't you? I mean, as a patient, I wouldn't know what to do. Surgical volume was less important. Now, actually, when they drill down on this specifically, so remembering that the Leapfrog group in the US work hard to try and inform patients about outcomes for hospitals, procedures, just to give patients more informed decision making about their operations. When they actually specifically asked the patients in this cohort, only about 40% of them recognise that volume or regionalisation of services may be important. It's only actually about 100 patients, obviously a qualitative study, in Michigan, in an area where there's a local oncology centre, but the regional oncology centre is about 2 hours away. So when they asked the patients who'd be happy to travel for their operation, you can see less than 30% of patients who all know that the regional cancer centre is 2 hours away are happy to travel 2 hours. So either they're not aware of the difference in the outcomes, or it's not as important to them as perhaps we think it is, because if there's minor changes, I think being away from your family for 2, 3, 4 weeks, however long it takes to recover from surgery, may not be what patients want. So then this is the study I think that Tim asked me to present more about. This was published in JAMA Surgery in 2019, really looking at the association between anesthesiologist volume and short-term outcomes following major GI surgery. So they looked at Ontario and they linked healthcare databases across the whole population of 13.5 million people. They looked from 2007 to 2018 across 3 major complex operations, as you can see here: esophagectomy, pancreatectomy, and hepatectomy. The primary exposure was the primary anesthesiologist, and what they looked for is the volume of cases that same anesthesiologist had looked after over the preceding 2 years. So if a patient was being looked after by an anaesthetist for an esophagectomy, they'd look how many esophagectomies had that anaesthetist anaesthetized for in the previous 2 years, just to try and get an idea of volume for the anaesthetist. The primary outcome for this study was 90-day major morbidity or readmission to another healthcare facility. They defined major morbidity as Clavien-Dindo 3 to 5 complication rate, which is something that makes patients stay in hospital infections to all the way through to death. They used a linear regression model to link the exposure, i.e. the anesthesiologist, or volume, whether that anesthesiologist was a high or low volume anaesthetist, to the primary outcome. And then they used statistics in that regression model to try and dichotomize the volume of patients that anaesthetists had looked after, to try and separate them out and have a cutoff value to produce a clinically meaningful cutoff, which in this study actually turned out to be 6. Obviously, this is a retrospective study, so they performed multivariable logistic regression after assessing the primary outcome against the primary exposure, looking for known confounders: age, sex, neoadjuvant chemotherapy, whether they lived in a rural situation or an urban area. And then what was really interesting, I think, in all of these retrospective analyses, I mean, myself and Tim have published a large data set for the Marsden. I think many people have. One of the things the authors always write in their discussion is, obviously, we couldn't account for unmeasured confounders. So whenever you could look at any retrospective data analysis, we don't know if there's some other effect that we haven't thought of that might have caused that association. So they use something called the E-value method, which I must be honest, I've not come across before, but I thought was quite neat. What this does is it tries to evaluate the chance of an unknown confounder being able to eliminate the association you found within your study. So in this example, their E-value was 1.6, which meant that if there was an unknown confounder, it would have to change the primary outcome by a factor of 1.6, so a 60% change, to mean that the association there found is invalid. I hope that makes sense, but it's a sort of a way of trying to measure that even if there are unknown confounders, how strong do they have to be to mean that the association found in the study is not true? And I'd not seen that before, and I thought it was actually quite neat. So what did they find? It's a non-linear association between anesthetic volume and outcome after surgery. And you can see here there's an inflection point between about the 50th and 75th centile, which was about 6 procedures per year. So this is the cutoff they used. So a low volume anaesthetist was doing less than 6 procedures per year, and a high volume anaesthetist was doing more than 6 procedures per year. So the composite primary outcome, which, to remind you, was 90-day major morbidity or readmission, was about 40% in this patient cohort. And actually, you can see here that the odds ratio, if you were treated by a high-volume anesthesiologist, was about 0.75. So this is unadjusted. So for those patients treated by an anesthesiologist who was doing this procedure regularly, they had a 25% reduction in their primary outcome. When this was adjusted for all known confounders with multivariable logistic regression, the odds ratio remained at 0.85, again suggesting that if you were to have surgery, you'd probably want an anaesthetist who is performing this procedure regularly. So then I'll go on perhaps to make some suggestions about some of the things that we may want to discuss around this topic. As I said, most of this data is from North America. I'm not certain how much of it applies to the UK, to other healthcare systems in Europe, Australia, New Zealand. So again, I think that's an important question. The distance travelled by patients will vary in different healthcare systems. The next question I think is really important. Is this data actually available for patients? In the US, there's the Leapfrog group who can try and advertise this. I mean, in the UK, probably know the data better here, we have individual surgeon-related outcomes, but I don't know necessarily we have advertised institution-level outcomes. Should this be out in the public domain? Do patients want to know this? Do patients want to travel for their care? Are they happy being away from their relatives? Can we facilitate that within the NHS? If there was one hospital, say Derriford, where Dan works, was the best hospital for a certain procedure, can everyone go and stay in Dan's back garden and camp and, have their operation there? Does it work in a healthcare system like the NHS? I think the other thing, in terms of the clinicians is what are the elements that mean at institution level, high volume is important. A lot of this is around team working. That's the whole team, radiology, nursing, radiation oncologists, surgeons, obviously perioperative physicians, critical care doctors. I mean, personally, I work with two surgeons, basically, when I'm providing anaesthesia. I know that we talk about every single patient having a major operation. He'll ask me, do you think this patient is well enough to have neoadjuvant chemotherapy? Is there anything we can do before the operation that we can optimize this patient? We will decide which cases we go ahead with, which patients have neoadjuvant chemotherapy, which ones don't, and which ones we change the kind of procedure they're doing. Now I'm lucky I just happen to work with two surgeons. Can that work across multiple consultants and multiple hospitals? Is there anything specific a high caseload anaesthetist might do? Are they specialists in fluid management? I mean, there's lots of debate. We heard yesterday with the great fluid debate, still within perioperative medicine and critical care, debates around fluid. Analgesia. Again, I think, a lot of the outcomes we've talked about around mortality, but I think, for patients, chronic pain after surgery is a major problem, affecting 15 to 30% of patients. And again, anaesthetists who are very used to these kinds of procedures, whether it's breast surgery, which has a high proportion of chronic pain, thoracotomy pain. Again, anaesthetists who are involved in that regularly are more likely to be comfortable with sort of techniques which may reduce post-operative chronic pain. I brought in other intraoperative managements, propofol versus volatile. As I said, I'm sorry, that's just a shameless plug for a trial that I'm involved with at the moment. But also post-operative management. Again, I get a call from the surgeons I work with. If they've got a problem on the ward, they just phone me up and say, Sham, can you come and have a look at the patient on the ward? Because they're not sure what to do. And so, we'll help. And, failure to rescue, again, is a very important thing, particularly at the institutional level, in terms of rescuing patients who develop complications after surgery and making sure we intervene early enough. And lastly, in the paper, they talked about whether we should be providing almost subspeciality anaesthetic groups. So in a hospital, should you have a group of esophagectomy anaesthetists who only do that? Now, I think from the paper and from the data we've seen, perhaps that may make some sense, but I think for any clinical director, they'd be thinking, how the hell am I going to provide that? If I've got a team of 6 people to do that, are they then on call the whole time? Because if there's an emergency, which is the highest risk time, do you then get somebody else to take charge of that high risk case? And it becomes very difficult to manage. So again, I'd be interested in obviously the panel's views and other views of whether actually anyone thinks that's feasible or a practical thing for us to achieve. So that's why I'd leave it and I'll let our chair begin the discussion.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.